lectures on a wide variety of topics. It's my pleasure to introduce Dr. Zubair Salim, my moderator. You want to introduce yourself?
To Zubair. I am working as associate professor at Sims, and I have a presentation, and I warmly welcome all the guests, especially the foreign speakers. It's a pleasure for having them, and we are looking forward to a very good interactive and informative session, inshallah. Thank you.
Thank you, Dr. Zubair. In the interest of time, we'll probably get started. I think Dr. Ibrar is gone to load his presentation. Could I check with if Dr. Imran Akram Sahaf is here? Right. How about Dr. Zubair, sir? You see your presentation ready? So we'll get started. My pleasure to introduce Dr. Zubair Salim, who's going to talk on a very challenging topic, cryptophthalmos, surgical treatment of congenital symblepharon variant. Just to check, Dr. Amar Yaqub, are you okay? You're here. Dr. Samira, of course, celebrity is here, right? Dr. Khwaja Khalid Sharp. Right. I know Dr. Grover is not here today. Dr. Yasser Khan is here. Dr. Farzad Patel, my good friend, is here. And we will get started, and time permitting, we'll have some good discussions. Feel free to be interactive and post any questions for the speakers. Dr. Zubair.
Thank you. I am going to talk about the clinical spectrum of cryptophthalmos and the surgical treatment of congenital symblepharon variant of the cryptophthalmos. We are quite familiar with the cryptophthalmos. This is the overview how we are going to proceed. Of course, we know that cryptophthalmos is a rare congenital disorder which is characterized by the failure of formation of eye fold and therefore failure of formation of the eyelids. In cryptophthalmos, the forehead skin passes continuously to over the eye and over the cheek. It is often bilateral and symmetrical, and it may be autosomal recessive or dominant. And usually in complete cryptophthalmos, the globe is often abnormal, resulting in poor visual prognosis. Briefly, it is divided into three main types. Most common is the complete or typical type. In this case, the eyelids do not form completely. The skin passes from the forehead over to the cheeks, and the underlying globe is also covered, and it is usually adherent to the overlying skin. Other features that are to be noted that the patients have got a broad nasal bridge, and there may be notching of the nostrils, and a characteristic feature is that there is absence or malformation of the eyebrows, and there is a lateral downward sweep of the hairline from the scalp to the lateral side of the eyebrows. Often these patients have a dimpled nose or a bifid nose, and the abnormal eye globe may be associated, as in this case, with the cystic remnants also. So this is the most common variety, complete. Then we have the incomplete or partial variety. In this, rudimentary lids are present, especially in the lateral part, with small conjunctival sac also there, and but in this case, medial skin of the lids passes completely over the eye globe, which is usually again disorganized. This patient has incomplete or partial or atypical cryptophthalmos on right side, while a complete cryptophthalmos on the left side. The least severe form is a form which is known as abortive cryptophthalmos or congenital symblepharon variety. In this, the patient usually has a formed globe. Okay? In the other two varieties, the patient has disorganized or malformed globe, while in this congenital symblepharon variety, the patient has formed globe and the eyelids are absent, and where they are absent, that is replaced by skin fold or a sheet of skin which is fused with the upper and medial parts of the globe. So due to this fusion, this is known as congenital symblepharon or abortive cryptophthalmos. Other features are also to be noted. This case also has a bifid nose, and there are rudimentary lateral part of this lids present, lower lids and punctum are all normal. So this cornea is covered by keratinized and stratified epithelium. So these were the three main types, just an overview. The various associated ophthalmic features, in addition to the skin folds, are there may be microphthalmos, there may be disorganized anterior segment, or there may be adnexal abnormalities like dermoids or absent of lacrimal glands or accessory glands. So these are the main ophthalmic associations. Similarly, these cases have a systemic association in the form of mental retardation, mid-facial anomalies, including those of the nose and ear, and there are hernias, there may be urogenital anomalies, syndactyly, and anal and laryngeal atresia. And when these conditions, systemic features, are combined with cryptophthalmos, this is known as Fraser syndrome or Francois syndrome or cryptophthalmic syndrome. To diagnose this syndrome, we need to have certain major criteria and some certain minor criteria. And if there are two major and one minor criteria, this classifies for the Fraser, or one major and four minor criteria. We had a case of Fraser syndrome lately. 2 months old child presented with abortive cryptophthalmos, again conjunctival corneal keratinization seen, and this patient had a positive family history of his sibling with complete cryptophthalmos. This positive family history also falls in the major criteria. Other features were he had syndactyly of feet, hands and feet. He had umbilical hernia, and on preparation for EUA, we noted that there was laryngeal stenosis also, and of course he also had genital abnormalities. So this was a spectrum of cryptophthalmos. It may present in isolation or in association with systemic features. If with systemic features, this would fall into the category of Francois syndrome. Apart from clinical diagnosis, we need to have CT scan or B scan to assess the condition of the globe, and a thorough systemic evaluation is necessary for further referral, which management is a challenging task for ophthalmologist. It involves staged reconstruction of the eyelids, fornices, and ocular surface protection. Visual development should be attempted where feasible, but it is usually poor. And of course, we need to have awareness of the life-threatening conditions so that we can refer the patient properly. Now coming to the case presentation, we had a child, 4 months old, who was brought with complaints of malformed upper lid and prominence of the eyeballs since birth. He was the second child of parents born by spontaneous vaginal delivery, and there was again positive history of sibling who had complete cryptophthalmos in both eyes. Child had been put on lubricant drops and ointments. While assessing the visual function, the child could fix and follow the light with the right eye, but objected to the occlusion of the right eye, meaning that he had developed amblyopia in the left eye. B scan showed well-formed globe with normal posterior segment. Again, there was broad nasal bridge and dimpling of the nose. On pediatric consultation, no other systemic anomalies were reported. With closer examination, we noted that he had bilateral maldeveloped upper eyelids with absence of the lid margin, except a rudimentary part seen laterally. The eyelid with its specialized structures like meibomian gland, tarsal plate, and lashes was absent in almost 2/3 of the area, and this was specially marked on the left side where there was fusion of skin to medial and superior aspects of the globe, leading to corneal keratinization and opacification. Both lower lids were normal, and he had a shallow conjunctival sac present laterally. So, considering the fact that the lids were fused to the globe and the cornea was exposed and was getting opacified. Okay. Further examination showed that the anterior segment in the right eye there was normal looking eyelets with probably a thick pupillary membrane, and left eye details were not clear. Corneal diameters were 12 millimeter and tonometry showed 22 and 24 millimeters of mercury. On the basis of these findings and a positive family history, a diagnosis of abortive cryptophthalmos or congenital symblepharon variety was made. and keeping in view the condition of the cornea, surgical intervention was thought to be necessary to save the cornea. And again, keeping in view the extent of the globe in the lid involved, a lid sharing procedure was planned in view of the absence of normal upper eyelid in more than 2/3 of the cornea. The classical main lid sharing procedures that are described are, the classical one is Cutler beard and the other is lid switch flap or lower lid rotational flap. Our aim was to re-establish functional eyelids, to have adequate protection of the eyeball and to achieve reasonable cosmesis. Just for introduction, the Cutler beard is a well-known procedure. It is a classical lid sharing procedure, but there are certain disadvantages, like it lacks tarsus in the upper lid, so it leads to instability of the upper eyelid, and there is absence of lid margin and lashes, and the flap needs to be kept for 4 to 8 weeks to take up properly. The other method is Mustarde lid switch flap, which is also known as the pedicle or rotational flap. In this case, a pedicle.
One more minute. So we'll keep to time, and so that we'll have enough time for discussion, if that's okay.
Okay. In this case, a flap pedicle raised from the lower lid and is transposed into the upper eyelid. Now I'll go quickly because time is short. Surgical procedure, the right eye was operated first. This is not a good picture anyhow. The fusion between the lid and the globe was released by doing keratectomy, and a split was made in the lower lid lateral to the punctum, and it was swept in an arc down to the lower extremity of the inferior fornix. And now this pedicle was created. This pedicle then was rotated into the defect of the upper eyelid. From the lower eyelid, the pedicle was rotated into the upper eyelid defect, and this is the picture which shows that the pedicle has been rotated. The lower lid defect was left for healing by secondary intention. This is the end result of this lid sharing procedure. After 2 weeks, we divided the pedicle and restored the upper and lower lid margins. Then the lower lid was recreated by suturing. At the same time, the left eye was operated again, keratectomy was done, and the flap was raised from the lower lid onto the upper eyelid. This is after opening the flap, and this is the post-operative picture. 4 weeks post-operatively, we think that this is comparing it with the pre-op picture. The upper lid contour has been satisfactorily restored. I think good cosmesis has been achieved, and there was reasonable movement of the upper eyelid, although some symblepharon remained superiorly, which was not addressed. We plan to address it later on. And the lids, although they remained slightly open, but the corneal protection was very much improved. This was another case done in a similar fashion. 1 minute. And this is the post-operative picture of that case. So, advantage of lid switch flap are that it restores normal lid margin, there is lash continuity, and due to tarsus there is more stable upper eyelid, and it may be divided as early as 2 weeks, especially in children or in one-eyed patient. Disadvantage is it is a 2-stage procedure, corneal irritation may occur, and of course the donor site needs to be closed, and technically a little difficult. So, but we think that still switch flap is an alternate and useful procedure for the reconstruction of complex full thickness upper eyelid defects. Thank you.
Thank you, Dr. Zubair. Comprehensive coverage of 2 challenging cases, one of the most difficult things to manage. Very impressive results. We'll save some time for discussion towards the end. My pleasure to introduce my fellow co-chair, Dr. Ibrar Hussain, who will talk to us about the art and science of ptosis surgery. In 8 minutes. I kindly request everybody to stick to time so that we can have meaningful discussions and contributions from everybody. Sure.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Mr. OSP Lahore. Take. Thank you. Now, the art of ptosis surgery, very difficult to cover in 8 minutes, but let us rush. So, case selection is very important. So, first of all, age of the patient, assessment is difficult in small children, because good assessment is needed for a good ptosis surgery. Early surgery, if pupillary axis is covered, you know about the amblyopia, that can be delayed up to the school going age if no danger of amblyopia. This is what our routine is here. Anesthesia, you know, general anesthesia or local anesthesia. I prefer local anesthesia up to the age of about 15, 16. Below that, it's become difficult because the local anesthesia, during local anesthesia, you can assess the patient during surgery that whether the lid height is and contour is proper or not. Then fascia lata, you know, can't be taken before 6. Then important thing is the amount of case selection is to exclude myasthenia gravis. This is very important, not only for ophthalmologists, but also for the anesthetists. Because if you give long-acting muscle relaxant to them, then it's very difficult to recover the patient. So you have to exclude myasthenia gravis. You have to exclude pseudotosis. So many patients have been referred to us. You all, the oculoplastic surgeons, know that they are not true ptosis and they are sent for ptosis surgery. So you have to exclude pseudotosis. Then you have to exclude mechanical ptosis due to tarsal disease like giant papillae. So you have to avert the lid of every patient so that you have to exclude those causes of mechanical ptosis. And jaw winking. Sometimes jaw winking is very mild and you may miss it. Then counseling and consent. This is very important because the expectations of the patients and parents is very high. So you have to explain to them that you not always reach to those expectations. Therefore, you have to counsel the patient and their parents first, and you have to take the consent. Then, of course, you have to select the procedure. There are different procedures are there: levator resection, tucking, levator epineuritis repair, frontalis sling or suspension, and muloconjunctival resection. So we will discuss only two of them: levator resection and the frontalis sling. Now, levator resection, first of all, marking the crease line before local anesthesia. You have to select, and sometimes if there is a good levator function, you have some crease there, so you have to mark that area. If no crease is there, then you have to take help from the other eye and you have to measure and properly draw the crease line. Anesthesia, you have to select, as I told you, that if local anesthesia, if possible, that's much better because during the surgery you can assess. Then incision. Important thing is the incision should be in one go. If you give a crease incision, usually if you take off your knife, then there will be a step there. So because it's a cosmetic surgery, therefore you have to go in one go the incision. Then orbital septum is a multiple layer structure. This is, I have selected those points where we can miss. Now orbital septum, I'll show you in the next diagram that where you should look for this orbital septum, because if you are not careful, you can go directly to the epineuritis and sometimes you can cut the epineuritis as well. This protrusion of the suborbital fat, this is very important, and when this is an important landmark, and the epineuritis is lying just below this fat. I'll show you in the video. Then identification of the Whitnall ligament is very important. Whitnall ligament is a very important structure and you have to identify. Then palpebral part of the lacrimal gland on the lateral side, you have to take care of that. So these are certain precautions you have to be very, very careful during the surgery. Now, here if you can see, what I wanted to stress upon this area, this is the orbital septum. So if you give an incision here, the crease is usually in this area. So you don't go directly down. You have to go a bit up and then will you reach this septum and this pad of fat will protrude. If you go directly, then you can cut the epineuritis. So here you have to be very careful that you identify the orbital septum carefully. And this is the Whitnall ligament. You can see here, the important thing here is this is the Whitnall ligament and these are the horns of the epineuritis. So in surgery, we have to cut the horns. So by mistake, you may cut this Whitnall ligament. So be careful not to cut the Whitnall ligament. You cut the horns which are attached here on the medial and lateral side. And on the lateral side, you have to take care of the lacrimal gland. Then again, vessels, you have to, of course, because the bleeding, less surgery is required, so you have to take care of these vessels. So this marginal arcade, the peripheral one, comes when you elevate the epineurosis. So you have to take care of this as well. Now, इसको जरा चलाएं. Now you see here, in this case I have not marked because the crease is visible. So you give the incision in one go. This is important, as I told. Then you use the Westcott scissor to cut the underlying muscle. Then below that muscle, this is the white structure. Can you see this white structure? This is the septum. So here you have to go a bit superiorly rather than inferiorly. And when you cut this, give a snip in the, here you'll see a pad of fat. You see, this is the pad of fat which is visible. So below this pad of fat is the epineurosis. So this is very important landmark. So you have to identify. Now you can see this is the whitish one is not the septum. Here is the epineurosis. Now here the epineurosis is being separated, and then this is elevated. Now a bit blood there, but the separation of the epineurosis, not very good video, sorry. Now this is the epineurosis. Can you see the epineurosis here? This is the cutting the horns. Now you can see the epineurosis very clearly. Then you suture this epineurosis to the tarsal plate. The important point here is when you take bite from the tarsal plate, remember this tarsal plate is not very thick structure, especially in the children. So you may pass through and through. Therefore, you should be very, very careful that this bite should be partial thickness, so that it should not go beyond the tarsal plate towards the conjunctiva. So this was now 3 sutures are taken, and then this new area of insertion is selected. What I do in local anesthesia, I take these loose knots and then ask the patient to sit and compare the height and the contour on the other side. And then if it is acceptable, then I resect. This is the resection of the extra muscle. Now important point on closure is that you have to make the crease. ये stop कर दें, next पे. बस stop. अच्छा ठीक. Now frontalis sling, some important points, marking and incisions again. Incision of the minimal size, about 2 millimeter, with blade number 11 at exact locations already marked. Now I usually use Fox Pentagon procedure. So Fox Pentagon or Crabford, some people use Crabford double triangles. The sling material. Now these are the points. You have to mark them first, and these are the different procedures. 2 of them are here. There are other procedures as well, but these are the most common one. Sling material, fascia lata at the top, and then there are pomaris longus tendon, temporal muscle fascia. These are the body parts. But then nylon suture, artificial one, the 50 ethibond, silicone rods. These are different artificial materials which can be used. Sling material should pass submuscular when you pass the sling material or whatever material, then it should be submuscular and should not be that deep, or neither very superficial under the skin, because the skin is very thin, so it can be visible through the skin. Then globe protection with a lead guard or scleral shell should be there. Multiple knots to attain a thick knot which is not slip down. We should not slip down. I'll show you at the end. You give the knot that should be a thicker one. Then superior poach for burring the knot. These are important points which need consideration. and suturing of the superior stab incision so that your knot should not expose. I do not suture rest of the areas. This is a 2 minutes video. Just I'll show initial part and then we'll pass because the time is almost over. Now these are the stab small incision, but this incision should not be that deep, and I use 11 number blade to make these incisions. And this the needle which I use, it's a 21 gauge needle to pass the, here I am using the proline, the 2R30 proline is used. Now you see we pass it from here. This clear shell is already down there so that the globe is protected. I pass the proline and then I'll pull it out. Similarly, from upper incision, stab incision to the lower one, here you should be very, very careful because you can penetrate through the skin or deep through the conjunctiva into the globe. So because the lid is very thin structure, so I passed it from there. इसको जरा आगे कर दो, थोड़ा सा आगे कर दो. थोड़ा और आगे कर लो. Now this is the final stab incision at the forehead. So the two ends will be pulled here and then a knot is applied at this area. This knot should be a bit thick enough, so multiple knots are applied. And I'll suture this area. इसको खत्म कर दें. That's it. And this knot is buried and then a suture is applied to this incision only, not rest of the others, because these are small incision. Here we apply suture because the knot should not be exposed. Thank you very much.
Thank you, sir.
Thank you, Professor Ibrar, for such an elaborate presentation. The next presenter is Professor Amir Yaqub. He would talk about upper eyelid reconstruction.
Thank you very much. I'll just take this opportunity to thank Lahore OSP for inviting me. Right. So I'm just going to talk briefly about the principles of upper lid reconstruction in 8 minutes, I hope.
That's all right.
Right. So what are the goals of reconstructing a good upper lid? We want to preserve the normal eyelid function, which is protection of the eye, and also restoration of as good a cosmesis as possible. Technically, it is easier to reconstruct eyelid defects after tumor excision because you know the margins and you know the tissues which are available. And sometimes after trauma, it's difficult because sometimes there is tissue loss and infection and stuff. And you have to excise more tissue there. So what are the general principles of upper eyelid reconstruction? They depend on the extent of the eyelid defect, the extent and the state of the remaining periocular tissues. We need to know the visual status of the fellow eye, because if the other eye has poor vision, we don't want to do a procedure of lid sharing where the eyelids are going to be closed for 6 to 8 weeks. The general age and health of the patient, that's important because you don't want to do a very long procedure on a not very healthy patient. And also depends on the surgeon's own expertise, how well he can manipulate eyelid tissues. The general aims, the first and foremost is to have a smooth and mucosal surface to line the eyelid and protect the cornea. That is the most important. That is the primary aim of your reconstruction of the upper lid. Then you must have an outer layer of skin and muscle. As you know, the eyelids has two lamellae, the outer one of skin and muscle and the inner one of tarsal plate and conjunctiva. You need to have a structural support between the two lamella, which is provided by the tarsal plate originally. You have to have a smooth, non-abrasive lid margin, which is free from trichiasis or keratin. And in the upper lid, you need to have a normal vertical eyelid movement without any significant ptosis or lag of thalamus. You need to have normal horizontal tension with the lateral and canthal tendon positions, normal apposition of the eyelid and lacrimal punctum to the globe, and a normal contour of the eyelid. So all these are important, but the first one is the most important here. So with a large eyelid defects, you generally require a composite reconstruction where one of the lamella has to be a flap, and the other one can be a free graft. So you can't use free grafts for both lamellae. It is so that's the basic important point. It is also wise to master simpler techniques if you're starting to reconstruct eyelids before you move on to more complex ones. So smaller eyelid defects, if they're 25% or less, they can be closed directly, but depending on the lid laxity, you can even close up to 50% of the eyelid defects with just mobilizing the two ends of the cut eyelid. With larger or moderate defects, you can do a canthotomy and cantholysis to mobilize the eyelid from the lateral canthus, more commonly known as the tensile flap. You can do a canthotomy and cantholysis and move the eyelid medially to suture it with the medial remnant of the eyelid. For larger defects, you need a free tarsoconjunctival graft, like a Hughes procedure, or from the nasal mucosa or nasal mucosal cartilage, or you can use a Cutler-Beard procedure. This is again a two-stage procedure. You can also use a lid switch flap, as Dr. Salim has also already shown you. For medial defects of the upper eyelid, you can do glabellar flaps or bilobe flaps or rhomboid flaps, or a median forehead flap as well. So just show you a small video of this glabellar flap. The upper angle of this flap should be less than 60 degrees, and you need to, once you've excised it, then you mobilize the glabella andomine along the submuscular plane, and once you've mobilized it, then you move the flap over the defect and close the upper forehead incision with I usually use Prolene for that. And then you can just move the flap into the defect and excise whatever is extra. And once you've excised that, then you need to suture it back into the defect. So this extra triangle of tissue is trimmed off, and this is the final reconstructed defect. So you can also do a full thickness skin graft for medial canthal lesions, or you can do a laissez faire, which is just you leave it to heal by secondary intention, and that sometimes gives you good results as well. Thank you very much.
Well ahead of time, so you're a trendsetter. Thank you very much, sir.
So next we invite to our next speaker, Dr. Samira Irfan. She will talk about ocular myasthenia management. She is not only oculoplastic surgeon, she is also pediatric ophthalmologist.
All right.
Assalamu alaikum, everyone. Thank you for inviting me, and welcome Dr. Gangadhar Sundar. We have interacted on many forums in India, and it's a pleasure to see you here in Lahore.
Thank you.
Hope you enjoy your visit.
Thank you.
So I'll be talking about the varied clinical presentations of ocular myasthenia. Myasthenia is not a rare problem. It's it is a common problem which is undiagnosed, underdiagnosed, misdiagnosed, because we are not expecting it. So it's very important that as oculoplastic surgeons, pediatric ophthalmologists, we are aware of this problem, its varied presentations, and keep it in mind that this should be the cause unless it is excluded. So its clinical presentations are, the varied clinical presentations are that it could present as ptosis, which could be unilateral, bilateral, symmetrical, asymmetrical. It could present as ophthalmoplegia, and it can mimic any ocular motor nerve paresis. Any muscle can be affected. So all these patients, they were mostly undiagnosed. They were either sent to me for surgery. They came for second, somebody had already put them on the waiting list for surgery, and they came for second opinion. So this 18 months old baby presented with this bilateral symmetrical ptosis, and he was not feeding well. So he was sent for a prostigmine test, and I'll show you the pictures. Then 3-year-old, again misdiagnosed, presented with ptosis, a bilateral ptosis, unilateral, again bilateral. She's been undiagnosed for the last 7, 8 years. And she's missing schooling. She's like this. She was a good student, but she was now unable to go to school. And she was still undiagnosed as having myasthenia. Similarly, in adults, so no age group is exempted from having ptosis or from having myasthenia. Unilateral ptosis, ophthalmoparesis, again, this girl, she developed ptosis suddenly at the age of 14. Now she's 28. And she is losing weight, she's not eating well, and she's still undiagnosed as having what the problem is, and she's losing her health. This elderly gentleman, he presented with this ptosis and supposedly a third nerve paresis. So this is not third nerve paresis. I'll show you his video later. And then again, another lady with unilateral ptosis. Then sudden onset of vertical diplopia and upward deviation of the left eye. Again, there was a mild superior oblique paresis, as you can see here, with marked inferior oblique overaction. So all these patients, they were undiagnosed, misdiagnosed, put on the waiting list for surgery, and they came for second opinion. So he had a positive Bilkowski test with absent diplopia on the contralateral head tilt, but increased diplopia and increased hyperdeviation due to this inferior oblique overaction on this ipsilateral head tilt. So in any acute or ocular motility disorder or ptosis, you must exclude trauma, myasthenia, intraocular space occupying lesion, demyelinating disorder, and if it's diabetic or hypertensive, especially in the middle age or the elderly. So patient presenting with ptosis to the oculoplastic clinic, you must know the onset, and the onset you should always document with previous pictures. Patient says that he has congenital, okay, that's fine. But if it appeared, say 10 years even earlier, and it's still there, like I showed you the picture of a 14-year-old, when she was going to school, she had no ptosis, absolutely fine eyes. So you must document, get the proof of picture, then know the history of variability, fatigability, generalized symptoms, must see a photograph, and myasthenia should be suspected in every case, unless ruled out by history examination photographs. So ptosis in myasthenia could be anything, asymmetrical, symmetrical, unilateral, bilateral, with good levator function, always good levator function. Sorry, in 8 minutes, I will skip through to the test, but I cannot explain the underlying basis. Why these tests, why good levator function? It is good, but you can ask me later. Diurnal variation, Cogan stretch, good orbiculary stone, brisk saccade, sleep test, eye spec test. Very easy to do in clinic, and they will give you the diagnosis. Fatigue test. This is the curtain test. You ask the patient to look up for a minute, and the lid goes down like a curtain. And if you want to know whether the upper lid, the ptosis is there, you have to lift this up manually, and the other lid goes down. So in all these children, we did the prostigmine test, and look, it is absolutely positive. So they were all put on the waiting list for surgery by other oculoplastic surgeons. Similarly, ptosis with ophthalmoplegia, the prostigmine test was positive. So none of them had to have surgery. Again, the patient with diplopia, as soon as we give the prostigmine, the diplopia disappeared and the hyper deviation, it also improved. So investigations in as these patients, CBC, ESR, thyroid function test, because in most of these cases it's an autoimmune disorder. So thyroid function test should be done as well. Acetylcholine receptor antibody, that is positive in about 50 to 70% patients with the ocular myasthenia. In children in the pediatric age group, this may not be positive because this is called the congenital myasthenia syndrome. And in those, the other antibodies are positive, the anti-MuSK antibody and then acetylcholine receptor enzyme. They have antibodies to the enzymes. So those antibodies are positive. Acetylcholine receptor antibody may not be positive. And then chest CT scan for thymoma. That is very important, and that has to be done with contrast. And if that is there, then you have to send the patient to the surgeon for removal, for excision of this thymoma, as antibodies are provided by this thymoma, and unless that's removed, then in most of the cases it is curative. So management is a stepwise approach. In children, the dose is 7 milligram per kg per day in divided 3 to 4 doses. The duration, the onset of action of prostigmine, it takes about half an hour, and then it stays for 4 hours. So you have to explain to the patient, educate the parents or the patient that the duration of action of this pyridostigmine will stay for 4 hours, and after that the drooping will start again. So they have to monitor, titrate the dose according to the level of their activity. Prednisolone can be given on alternate day, not to children but to adults, and it helps in cases in which there is ophthalmoparesis mainly. Or if this doesn't work, then azathioprine. In the congenital myasthenia syndrome, these days they are giving allobuterol, and that is effective in those. Surgery, as a thymectomy, plasmapheresis may be tried, and regular follow-up. It's important to educate these patients because ocular involvement is in 90% cases of known myasthenia gravis, and with ocular myasthenia, 60% present with this feature. 50 to 70% undiagnosed cases, they progress to within 2 years to generalized myasthenia. So it's important to diagnose it, regular follow-up, look for systemic involvement, and ask the patients about dysphagia, dysarthria, breathing difficulty. So thank you. Keep it in mind in every case, unless you have ruled it out. Thank you so much.
Okay. We were eagerly waiting for Professor Imran Saab. He is my worthy respected teacher. I request him to present his talk on challenges in congenital coloboma. Okay.
Do keep your questions ready for all the speakers. Once all the speakers are done, we'll have a nice discussion. But great talks so far.
Bismillahirrahmanirrahim. We're going to talk about congenital coloboma. There's a number of causes for it: absence of union between contagious TB, failure of the mesoderm to fill that for an amniotic band syndrome. Incidence is rare, but it's 20%. It's about bilateral, and they are small, large, and medium. The defect can be a full thickness defect or a partial thickness defect. That consists of a skin, muscle, tarsal plate, conjunctiva, and all four can be absent or two can be absent. So whenever there is congenital coloboma, there are other problems as well, which have to be looked into. There's exposure, the symblephrons, keratinization. The major problems arise when we operate is because of the levator defect and absent fornices. I come to that. So immediate measures have to be taken. I've seen patients being referred without taking care, and by the time they arrive, they've got corneal abscesses and they've got other problems. So the eyeball has to be protected, and we are using a wet chamber designed. You can see this patient has already got a perforated cornea. So we've got a wet chamber designed. We've got a cellophane membrane, and we put in some ointment and cover with the membrane. This provides a wet chamber, and this can protect the eye indefinitely, at least while we are preparing for the surgery. So the aim of treatment is basically the closure with 3 layers and then the movement of the eyelid. Because we are not just constructing the eyelid, but we also want movement. So what is plastic surgery? I feel it's a knowledge of the behavior of the tissue used for the benefit of the patient. Unless you have got the knowledge of all these things, vascularity, elasticity, resilience, healing, all of them, unless we know them, we can't do a plastic surgery. We put in sutures, the next day they are cut through. We make put in a graft, and next day it is necrosed because of loss of less vascularity. So we need to know all these things. So surgical managements, they're different. Direct closure with cantholizer, catalabia loaded, so many, depending on the size of the defect. So this is a direct closure. We need drawing of the surface, passing the mattress suture through the firm tissue. That is important. You have to pass the mattress suture through the firm tissue and apposition of muscles and tarsus. So this is, you can see the coloboma. As you can see, this is all the layers are not missing. Here you can see skin and conjunctiva are present, but muscle and tarsal plate are absent. So we have to first remove that area, raw that surfaces. So got a pentagon of incision. We have created a raw area. Now you can see the conch, the muscle, and the skin, and they have to be sutured in layers. So they have to be sutured individually in layers, not in one layer. So they are putting in the sutures, and then there you can see them. There it is. As I said, we need knowing the behavior of the tissue. Once you have closed the coloboma, the lid looks very tight. It feels that it's not going to blink or all that, and in a few days it relaxes. Right. This is the beauty of the nature. It relaxes, and you get all the movements. So, and then you have got direct closure with cancer. When the defect is large, we have to do a bit of relaxation at the lateral cancers. So we have to exposure of and cutting of the upper crust of that. So there you can see a large defect. The procedure is the same. We raw the surfaces, and then we do a cantholisis, the upper crust. It's a large defect. And then again we tend to do direct closure. It's very interesting. As you can see, once we have stitched the upper lid, you can see the lower lid is redundant. So you feel that we have tightened it too much. But in a few days, you see the lower lid goes into place because the upper lid has relaxed. And the tension is gone. Then we have to do a cutter beard procedure, which is a lid shearing procedure. And there we measure the defect, and then again we raw the surfaces. But this time, This time we are going to fill the gap by tissue taken from the lower lid. So 3 layers: skin, muscle, conjunctiva, and the tarsal plate. They are all taken, and then we fill the gap in the upper lid. I will show you how. And to create a tarsal plate, we can. I sometimes take the cartilage from the ear. So stitching is again done in 3 layers, and then separation of the lid is after 4 to 6 weeks, and the construction of lid. So here is a large defect. There it is. There I have. You can see where the surface are raw now. We have to be very careful that we are in the firm tissue. That is important, because when we are removing this tissue has to be firm where we end. And there you can see there's upper, and this is the graft we are taking from the flap we are taking from the lower lid. There's a full thickness because of skin, muscle, and conjunctiva. We pass that under the bridge into the gap. I will show you how. This is what we have created, and this is when we create this raw surface, the defect looks very large. But if you just suture them together to find that the defect is not that large, so you need a smaller flap. And there it is, the lower one. It is below the bridge. We take it up and stitch it again in layers. Conjunctiva with the conjunctiva, muscle with the muscle, skin with the skin.
Yeah, just right.
So this is the final one. There you can see. That's the final one. Now, it's not always so easy, not always the same. We do have problems, especially with the obliterated fornices. If the fornices are obliterated, as you can see in this child, there you can see the obliterated fornix. So if we create a lid over here, this lid is not going to move, it's not going to open, the eyeball is not going to move. So we have to create a fornix and make the movements possible. So there you can see. So I use an innovative method. I will show 2 methods I use to create the fornix. One is this one. As you can see in this child, you can see the skin and the keratinized tissue extending onto the entire surface of the cornea. So this extra tissue in the form of keratinized mucosa, that can be used to create some fornix. So there it is. There you can see the gap. I have moved the conjunctiva upwards. As you can see here, this is the tissue which has been moved up and to create the fornix. And I stitch it here, and with the sclera, this area gets epithelialized by itself. And here we can then create, and there you can create the lid by cutler beard procedure. Fornix being created by the tissue we have taken from the cornea. Then this is what happens if we are not careful. This patient has been operated for lid formation, cutler beard procedure, and you can see the adhesions all over and no fornices. So in these patients, what I do is, first I assess the depth of the adhesions. As you can see, the whole of the lid is not adhering. We have got areas around around the adhesion which have got conjunctiva and the fornix. These areas are open. So once we have assessed that, we separate the lid from the cornea and that is the area which is raw. This is raw area which has to be covered to create a fornix. So what I normally do is, I just, as you can see here, I do a limbal incision in the conjunctiva. Then I undermine the conjunctiva on either side and create flaps. This is the flap. I pull it over, and there you can see flaps from both sides being sutured in the center. And this creates a fornix. And on top of that, we can create the lid. On top of that, we can create the lid. So this is how we go about, all the cases are not the same. So we have to deal with certain problems. Then opening is equally important in cataract beard procedure. As you can see, this is the probe passing under the bridge we have created. Opening, and the important thing is that when we separate the lid, the skin, the conjunctiva is cut in excess of the skin. Barabar nahi, not equal. Reason, there's an extra conjunctiva, and that conjunctiva is wrapped around the margin of the lid, so that this keratinized skin does not rub on the cornea. So this is, and then there are other problems as well. There's a total lid loss, and for that we do Mustardi's lid rotation. The whole lid is, lower lid is rotated into upper lid, and then separated, and a full thickness upper lid is created. So in the conclusion, it's a knowledge of the tissue behavior. The better the knowledge, the better is the procedure. We need knowing about the tissue structure, vascularity, and so many things. And to cap it up, it needs a lot of hard work, perseverance, multiple procedures. You have to deal with the impatient patient, and a lot of, you have to tell them what you are doing, what are the expectations. Patient expects a full normal lid, so that's not possible. And once we have created the lids, we have to create lid movements, and especially in cataract beard and full thickness, we have to do sling procedures to create that. Thank you very much.
Thank you for your good lecture. And now I'm inviting Khwaja Khalid Shoaib for his presentation on cicatricial entropion.
Thank you, Professor Sahab. Your talk was just fantastic. You can make out the real experience. He's speaking on each one of the cases you presented. So thank you very much. It is very nice. While we invite Dr. Khwaja, any quick questions for any of the speakers while his talk is ready? It's ready, right? Okay. Carry on, please. Can we stick to 8 minutes so that we can have time for discussion? Thank you.
Okay, thank you very much. And see, this is the entropion, is the turning in of the eyelid margin. Is usually because of the scarring of the tarsal conjunctiva. The lid margin loses its square edge and is rotated posteriorly, and the lashes abrade the cornea with the resultant watering, lacrimation, redness, photophobia. So differentiating the involutional entropion from cicatricial entropion. The attempting to return the eyelid to a normal anatomical position using digital traction will correct the abnormal margin position in involutional entropion, but not in cicatricial entropion. So in cicatricial entropion, the lid deformity would remain there. Now, etiology includes infections like trachoma, herpes zoster, autoimmune disorders like cicatricial pemphigoid, inflammatory like Stevens-Johnson syndrome, surgical like enucleation, posterior approach ptosis correction, traumatic like thermal, chemical burns, scarring, topical glaucoma medications, especially miotics, long-term use of miotics, and chronic conjunctivitis. So this is an article which uh, highlighted the relative frequencies of different causes, and the ocular cicatricial pemphigoid was responsible for most of the cases, while Stevens-Johnson syndrome, burns, and previous eyelid reconstruction were also responsible for significant cases. Then socket scarring, thermal burns, and post-radiotherapy pubian gland dysfunction is also responsible. So, uh, can anybody tell from the back benches what is this? Last two lines. Any clue? What is this? Any finding you can pinpoint? Uh, alt line. What is the complete name of alt line? Jash alt line, right? So it indicates what? Good. So this white line was a characteristic feature of trachoma, which was very prevalent 30 years back when we started ophthalmology. We would encounter many such cases, and the patients would come with trichiasis, dystrichiasis, and the corneal opacities because of the inturned eyelashes. Now it has decreased in incidence. So, as far as effectiveness of the treatment is concerned, the cause does matter. In autoimmune or inflammatory diseases, frequent disease progression occurs. The prognosis is guarded. While in ocular cicatricial pemphigoid, patients may benefit from systemic chemotherapy, usually Depson, so the treatment can be partially controlled. Prior surgery trauma process, localized and reversible, usually gives a good prognosis. So the infectious causes fall somewhere in between. In mild to moderate cicatricial entropion, marginal entropion, the tarsal fracture operation is useful. A full thickness posterior horizontal tarsal incision is made 2 mm inferior to the eyelid margin, and this allows the eyelid margin to be rotated away from the globe in an everted position. The eyelid position is stabilized with everting sutures. See, the main purpose of surgery in cicatricial entropion is that we direct the eyelashes away from the cornea. So the eyelashes do not rub on the cornea and do not cause corneal opacity and decreased vision and lacrimation and blepharospasm and photophobia. So in severe cicatricial entropion, tarsus is scarred and distorted and needs to be replaced. In upper eyelid, tarsoconjunctival grafts can be used, and mucosal grafts is another option. In the lower lid, autogenous ear cartilage, preserved scleral graft, and hard palate mucosa are the indications. So, this is how we take the buccal mucosa. So, anybody can tell how far behind we can go while taking the buccal mucosa. What is the posterior limit of taking the graft? You can see this is the buccal mucosa. So we want to take the graft. What is the posterior limit? Anybody? Dr. Sabha? Good, excellent. So the parotid duct, which is coming and opening against the second premolar tooth, is our posterior limit. We don't go beyond it. So in contracted socket, the problem is that we are having no fornix and we'll have to do some surgery to make a space. We implant the septal cartilage and buccal mucosa to form the posterior lamella of. Now, this is the buccal mucosa from the lip, the posterior aspect of the lip. So, what is the upper or anterior limit? Anterior limit is the mucocutaneous junction, vermilion. So we avoid the mucocutaneous junction, and we can go. See, this is so we can take all this off. So as a first step, we hold the lower lip with towel clamp and ask the anesthetist to place the tube. Usually it is done under GA. So the anesthetist places the tube in such a way it does not obstruct it. It is on one side of the mouth. So telling the anesthetist is necessary so that you get the feel. And then once you have taken the buccal mucosa, spread it, and this is how we take the septal cartilage. And इसको play कर सकते? So we make an incision in the mucosa, then separate the septal cartilage, separate the mucosa. So once the cartilage is separated on both sides, then we take the so this is the septal cartilage. We have taken a piece and then we can use it lid reconstruction. So I'll not go into details of these. I will discuss the most common. So in upper lid entropion, gray line split, repositioning of anterior lamella, advancement of posterior lamella, and tarsal wedge resection. These are the commonly done procedures for the cicatricial entropion. This is anybody can tell what is this phase called? This is called leonine phase, line-like phases of leprosy. Now it is very rare, but previously it was very common. So it leads to cicatricial entropion, and this patient came to me and which last it? Okay, so we administer the local anesthesia and make an incision 1 to 2 millimeter deep at the gray line just behind the eyelashes, and we try that it is completed in one go. Then make an incision over the tarsal plate 4-5 millimeter above the lash line, and then we expose the tarsal plate and make an incision in the tarsal plate as a wedge. Make 2 incisions so that we remove part of the tarsal plate, and then we stitch the lid margin up above on the. So this is the final picture. See here we can achieve the fixation with 2 types of sutures. Either we bring the double arm suture from fornix and attach it on the lid margin, or we attach the suture to the anterior text. Okay.
1 minute left.
So you should have a bare tarsal plate of about 4 to 5 millimeter at the end of the operation, so that sufficient distance remains of the eyelashes from the cornea. So this is, thank you very much.
It's my pleasure now to introduce 2 great friends. First, I'd like to invite a great surgeon, an avid traveler, and like I said, a good friend, Dr. Yasir Khan. Welcome to this part of the world, you foreigner.
He's a regular visitor.
Sort of foreigner.
Who's going to talk to us about small incision browlet for facial palsy.
Assalamualaikum. While they load this up, I just want to thank the committee for inviting me. It's so wonderful to be back in Lahore after, I think was before COVID 3 years ago. And anyway, so nice to meet old friends and learn new things. Okay, good. Whenever you're ready to. So I'm going to talk about minimally invasive browplasty. This is the advancement. Awesome. Thanks. So why should glaucoma surgeons and cataract surgeons be the only people who have minimally invasive stuff? Why can't oculoplastic surgeons have minimally invasive things as well? So I'm a big fan. You're going through my entire presentation. That's okay. It'll be done in 2 minutes. No problem. I've got a USB too if you want to load it from USB. Is that okay? Thank you. Yeah, okay. So basically, I love minimally invasive stuff. I do a lot of my oculoplastic eyelid surgery, even DCRs and orbital surgery through minimally invasive incisions. And I've got a whole talk on that. But I mean, today we're going to talk about the eyebrow. But in general, small incisions take less time, are less invasive, better for patients, and are easy to learn. You have to be flexible. This is not working? Is it awesome? So I do a lot of my stuff through a very small procedure room. You don't need a big OR. This is in my office, so you don't need a lot of investment in being able to do small incision oculoplastic surgery. You need courage, knowledge, guidance, which is not a lot of investment, at least money-wise. I use acronyms because we love acronyms in medicine, so need SCM. Today I'm going to talk about SIB, which is small incision brow elevation. I'm sorry, there's a delay in this, but maybe I'll say next, and will that be better? Okay, so let's talk about the small incision brow elevation. It's not for everybody, so definitely not every, it will work in every patient. You have to select your patients. And so this is the old way or the current way. It's not actually old. It's still relevant for the right patient, especially patients who have really bad facial nerve palsy. This is the classic direct browplasty, which many of us are familiar with. It's a large 20 millimeter incision. Works very well for the right patient. And you can see here, I mean, you do a large, subcutaneous flap down to the frontalis muscle. It's big surgery. It works very well, but takes a lot of time. And you can see here, there's frontalis exposed here, and then you use sutures to close it. And it's a pretty good result. Sorry, guys, there's a little bit of a delay in changing the slides. Okay, good. So this is what you end up getting. I use a horizontal mattress suture to get a good scar. And you can see very bad left brow ptosis, and you get a really good result, okay? And I mean, I really look at browplasty as a hierarchy of elevation. So the biggest, as we say in English, the biggest bang for the buck is really the direct brow, which gives you the greatest elevation. And you can see a nice result with a bit of a scar here. The midline forehead lift, especially for people who have wrinkles in their forehead, works well. This is a bad picture. You can see a scar here, but it's actually pretty good, but not as high as a direct brow. And then finally, the enterbrow lift, which I do not do. And I often can't tell the difference. I mean, nothing that Botox can't fix, but I'm biased against enterbrow lifts. No, with all respect to people who do them. Next. So what if you could merge the best of both worlds? What if you could do a direct browplasty that has the biggest impact, biggest bang for the buck, but keep it a small incision that's cosmetically present for the right patient, okay? And that's where the small incision browplasty comes. I have to go back. Okay. So basically, it's a small incision, fast surgical time. Takes me about 10 to 15 minutes to do. The incision's about 1 centimeter or less. It's a reduced scar. I'm able to adjust the brow height, and it's easy to learn. Next. Okay. So this is a little video of how I do it. Now, this is about a year old. Of course, when coming here, I forgot how I currently do it. Now I just make the one incision. You can play that. So the key thing to point out is I make the one incision now, but you can see this is combined with the blepharoplasty. I myself have not, at least in my hands, have not had a good effect with an internal browpexy during blepharoplasty. I just can't get the brow high enough, so I stopped doing it. I do these with my cosmetic patients, and basically I now make one incision, but you can make 2 incisions now. The key thing is to use a permanent braided suture. So I use 4-0 Merceline. You can use Vicryl as well, and that actually works very well for me as well. And Merceline is just as braided and it's permanent, right? And the key thing is to attach the subcutaneous area of the tail of the brow to the bottom orbicularis, brow orbicularis or frontalis muscle, and periosteum even. I used to use two incisions just because it was easy for me to pass my sutures. I just use one now, and I even excise a bit of tissue. So I even excise this bit of skin here. So it gives me almost like a mini brow lift with a really good, now it's not a drastic impact like you get for a direct browplasty, but it does the trick, especially for cosmetic cases or for subtle cases. And this probably takes me about 20 minutes to do for both sides. And the scar actually heals very well. I always tell patients if there's a scar, two things is you can use makeup, you can do tattoo, and there's different ways to heal the scar. Next. So you can see it's subtle, but not a bad effect, right? So here's a patient pre-op, and this is with a bleph and a subtle toe. So you can see subtle elevation. It's permanent, so you don't have to use Botox. Back, please. I'll let you know when it's next, okay? You can see here as well, subtle effect. So next. So there's a patient with a right-sided Bell's palsy who's had a bit of a right-sided deficit of her browplasty, which really, really bugged her. Clear forehead, okay? I don't do endobrows. And so we did a small incision browplasty. Next. And you can see I made a very small incision. I actually excised this bit of skin, okay? And this is a video that I did not have with me. But basically, this is how the incision looks. And I use the same Vicryl or Merceline. And this is only a month post-op, right? So this will definitely heal and it'll flatten out. But you can see, I mean, these are pretty even. So it's only this. And this will even flatten out and decrease. And I haven't seen her yet, giving a really good post-op result. This is her pre-operatively. Okay, so it does work, and it does have a lasting ability to at least 2 or 3 years. Next. So keep the patient in mind. Don't do shortcuts. Not for every patient. Be confident. You almost have nothing to lose. The scar is really minimal, and it's not even an issue, and practice makes perfect. Thank you.
Just fabulous. I would like to sit down with you and learn some of these techniques and incorporate my practice. My pleasure now to invite a great friend, Dr. Farzad Pakdel from Tehran. Farzad. And if those of you who suffer from COVID, from lack of meetings and conferences, he's the one friend I've been doing a lot of webinars with. He's more recently organized a fantastic International Thyroid Eye Disease Society webinar, everything you need to know about thyroid eye disease. And hopefully he'll be making it available for those of you who registered. Extremely well experienced, and he's going to share with us his perspectives on management of brow ptosis. Farzad.
Thank you, Ganga, for a nice introduction. Thank you for inviting me to this wonderful conference. Thank you, Dr. Main, Dr. Hagan, and other friends in organizing committee of this wonderful meeting. So I would like to share you some concepts very quickly in 8 minutes about the management of the brow ptosis in patients. So, yeah. Ready? Perfect. So I have no conflict of interest except for our book here that I used some material from book, and I was honored to be one of the contributors and writers of this book. So it's really essential to understand that many patients are coming to us with droopy eyelids. At least they have some parts of the brow ptosis, and we should look for that brow ptosis. It's not like that much obvious in every case. So first of all, we should understand what do we mean by brow ptosis, and look at the Venus sculpture here. Over thousands of years, the concept of the beauty has changed a lot. Look at the Venus here. You may see the flat brow a little bit downwards. That's not fashionable like you see in the lower part. Sorry. In the lower, can we have like a pointer here? Oh yeah, thank you. Like an arc eyebrow here. So what we name like an ideal eyebrow means we should have a symmetric brow, to be symmetric in position, appropriate volume of the brows, and the natural and youthful fullness of that actually volume of the brow. And to represent the gender, it's not a good idea to consider like a flat brow for a lady or a high arc brow for a gentleman. So we should respect the gender for the patients. And it should be harmonious to the face. For elongated faces, if you have that much arched brow, it may not harmonious for the whole face. So ideal brows, we should consider manufacturers for each patient. We have no formula for all cases. So let's review quickly what are the senescent changes of the brow. First, skin laxity. The skin laxes over the ages. Skin changes to be thinner. Deflation, the subcutaneous fat is displaced and actually gone. And we see some droopiness of the brow in the lateral part, in the medial part, in the middle part, sequentially in the patients. We are seeing like rhytids, the glabellar region, in the forehead. And we see some pigmentary changes. The patients that are looking for youthful appearance of the forehead and the brow, they are looking for all these components. It's not just a good idea to look at the droopiness of the lateral part of the brow. Let's bring it up. So look at here. All of these cases came for droopy eyelids, and look at them. There are many variable changes in terms of the dermatochalacia and the brow ptosis in different patients, asymmetric, loss of volume, actually lots of actually droopiness over there. So what are the surgical goals when we are planning for brow management? First, to elevate the brow in the part that's ptotic, in the lateral part, in the middle part, or the whole eyebrow. Reduction of the lateral hooding. And this is actually a very good sign in some actually subtle cases that showing a marginal droopiness of the brow. You may see that hooding in lateral parts, not the eyelid. It's not the skin. It's the eyelid, eyebrow coming down over here. So we need to elevate that hooding and reduction of the crow's feet and correction of the brow asymmetry if it's present. And look at this shape. This lady came for actually dermatochalasis over here. But a closer look, you may see that the brow over here is actually slightly ptotic compared to the other side. So the problem is not just dermatochalasis, the brow ptosis is over there. When you elevate the brow, you see part of that droopiness is corrected there. So if you just remove some skin, the patient will be unhappy after operation because some remnants of the problem still goes there. And brow asymmetry is really important. Many of these patients are seeking for to be a symmetric face, a harmonious face. And look at here, we have asymmetric brow ptosis, asymmetric lateral hooding for this lady here. And every case with the brow ptosis, you should consider if there's any history of the recent Botox injection, trauma, or surgical intervention over the face or skull. And some of these patients, like this young lady, came for lifting of the forehead, but the problem is not the eyebrow. The eyebrow is a hallmark to the eyelid ptosis. In some patients with unilateral eyelid ptosis, the compensatory of the elevation of the actually ipsilateral eyebrow happens. So in every case with asymmetric brow, you should consider that and check for that asymmetry to the patient. And the last but not the least, check what the patient wants about concerns of scar, downtime, costs, and preference, longevity of the actually downtime, and also the preferences of the patient, and to have a realistic view of his or her own image after operation. This is really important. You cannot do like a direct brow lifting for a young lady. You cannot go for very sophisticated endoscopic transcoronal brow lifting for like 90-year-old gentleman with lots of writing over there. So when you address the brow lifting, you should consider we want to make this more beautiful. Different types of the actual techniques like transcoronal can be used like a direct one, or endoscopic one or transforehead approach, or we can make incisions over the brow, or we can elevate the brow through the transpylapoplasty skin incisions. Let's review the pros and cons of some of these methods here. Transcoronal forehead and brow lifting provides us a great exposure. We can elevate the brow as much as we need, bring the asymmetry for the patient. We have some downtime for the patient. Nowadays, we prefer like endoscopic ones. For those that we approach through the high brow lifting, presbyopia, you should consider that skull formation, although it provides you a very good tunneling over that gallia, and very good, nice, very quick operation. But look at this scar. I've seen lots of cases referred to me because of that unwilling scar over there. So mid forehead lift, I rarely use that, but for like this patient, you may put incision over the depressed iritis over the mid forehead, very quick, and you can provide good satisfaction for the patients. And I enjoyed that talk. That simplified my job. So I learned this technique from my friend and my mentor, Guy Master in Los Angeles when I was there. It's minimal incision brow lifting that was somehow described in the modification of that. And I love that one. It can be regarded like some part, a cosmetic procedure. None of the, suprabrow incisions, to me, it's not cosmetic operation. They are just functional, except for this one. I saw many cases in US when I was there that the scar part was very low, but in the Middle East, I'm seeing patients that unfortunately the scar is visible over there. So when you are doing such operation, look which area and which type of people you are dealing with. But for the gentleman, if you can actually explain everything for a patient, it's a good idea to check the lateral brow lifting with this simple method. You just need to fix the eyebrow tissue, the periosteum over that area with the non-absorbent like 4O Prolene sutures. Very quick job, like 1 centimeter incision, very good healing. You can do it with other procedures like blepharoplasty. So it's useful for addressing the lateral hooding of the patient. In some of the patients that are not seeking for sophisticated brow lifting procedures, but you need to address that droopiness in the lateral part, you may fix the orbicularis oculi in the lateral part with the vital suture, the periosteum, and the opposite orbicularis oculi is called brachial sutures. It's not just elevation, it's just providing a good projection of that part and supporting the eyebrow from downward displacement after blepharoplasty. I need just 1 minute, Ganga.
Sure.
And like this lady that refused for endoscopic job and was very happy after that brachial suture. In this case, you have severe brow ptosis in the lateral, in the medial part, very bad, very complex asymmetry, transcoronal approach. To me, endoscopic is the only method you can address that kind of situation. But you should consider disadvantages. It's a high learning curve, the high cost, and very good operation for those like younger ladies, like younger gentlemen that address to correct the eyelid position, or like 23-year-old lady. This is the only one that I advise for very young people. So when you want to decide which procedure for brow lifting, you should have inputs from your evaluations, the goals for this specific case, and your preference in terms of the instruments, expertise, and then when you sum up, you will decide which operation goes well for your patient. Thank you very much.
Thank you, Dr. Fazad. I think we have had enough of upper lid. Let's not forget the poor lower lid. For this, I invite our chairman of this session, Dr. Gangadhara Sundar, who will present his talk on lower lid reconstruction.
Thank you. They have not connected the laptop yet, so I'll try to stick to my 8 minutes once I
It's
start.
okay, you may have 10 minutes because you were very particular about the time.
Yeah,
Anyways,
sorry about that. Yeah. So while the laptop is getting ready, wherever it is, yeah. Or just, there, very good. Okay, so just forward, backward. Okay. My talk has been made easy by a lot of our speakers, Professor Yaqub and Professor Sahaf, talking about upper lid deformities, and the principles or concepts the same. I'm being tasked about the lower lid deformities as such. These are my disclosures, a lot of work related to oncology and trauma, but no conflicts of interest related to the presentation. So if you look at the lower lid deformities, they can be basically classified, this is more for the residents and fellows, in terms of congenital deformities, which can be colobomas, beautifully addressed before, where an extension of colobomatous defects are the Clifton syndromes, and they have facial consequences. More commonly, we see a lot of traumatic deformities, which sometimes we manage very well, but sometimes we don't manage very well. Then deformities caused by various benign and malignant tumors, and finally other deformities itself. So these are the common deformities that we talk about. The principles, as addressed before, is first and most important, all the eyelids, upper or lower, should be opposed to the eyeball. In other words, you don't want the eyelids standing off the globe, and that's where the canthal concepts really come in. You have to have a mucosal, non-keratinizing mucosal lining. Ensure that the medial and lateral canthal angles go posteriorly, not just anteriorly, because you're going to have a standoff. Make sure the margins are clear if you're doing tumor resections, and compared to the upper eyelid, which is known to be mobile, the lower eyelids don't have to be mobile at all, which is a big advantage. And when you're dealing with medial canthal deformities, do not forget the lacrimal drainage system. So congenital deformities can be classified into isolated colobomas. You had beautiful talks right over here, where the upper is more common than the lower. The lower is less common, but is more common in situations where you have syndromic deformities, as you can see, this oculo-auricular-vertical syndrome. Don't forget to be the ophthalmologist who just ignores everything else beyond the eye. Make sure you look at the ears and refer these children for audiological evaluation, and apart from just doing an eyelid reconstruction. And finally, when you're dealing with these Clift's deformities, make sure you're aware of the various classification system, because no point fixing the lower lids alone, because unless you address the issues related to the midface and the lacrimal drainage system, just protecting the eyeball alone is not enough. So be aware of the clock face deformity classification. The next one I'm going to talk about is traumatic deformities, and this is something that I think all of us as medical students, as residents, as fellows really manage very well. And if you have simple incisional deformities or laceration deformities, very easy to manage, margin to margin apposition, the gray line, whether you put 2 sutures or 3 sutures along the lid margin itself. But it's a non-lid margin and the canalicular involvement deformities which you have to not ignore the lacrimal drainage system. And so be the oculoplastic surgeon, ophthalmologist, who looks at canalicular lacerations, intubates the system so that you protect it, and then go ahead and repair the deformities itself. So the principles of management of these deformities, if there's no tissue loss, approximate lid margin, approximate the deep layers, usually with absorbable sutures like Vicryl, and then approximate skin, and do not approximate the orbital septum. And that's the middle lamella of the royal eyelid, and that's where our craniomaxillofacial surgeons, if you leave them manage these midfacial and lower lid deformities, they suture the orbital septum, causing the retraction and tethering of the lower eyelid itself. This was talked about before about defects which are present in the lower eyelids and the upper eyelids. Less than a third, direct approximation is almost always possible. In children, any deformity that looks very large, if you really bring things together, a large defect actually becomes a medium to small size defect. So you oftentimes can avoid doing major flaps and reconstructions. It's a really large deformities that you want to think about really mobilizing large flaps itself. So talking about medial lid margin deformities, any laceration medial to the punctum involves a canaliculus until proven otherwise. So do not take the easy path out and say, yeah, medial laceration, but I don't think the canaliculus involved. No. These are the patients either under local anesthesia, general anesthesia. You can explore, you can irrigate, you can probe, all on topical anesthesia. And the moment you have a laceration, it doesn't matter if it's upper or lower, you're obligated to do the repair. I generally prefer bicanalicular lacerations. Other experts may choose a monocanalicular laceration, especially if you're doing under local anesthesia itself. And generally, either a Crawford or Rittling system is what is usually. When you have large tissue defects, yes, even the primary situations, you can do rotational flaps. Again, these can be generally done under local anesthesia. The older the patient, you have enough soft tissue leeway that you can undermine and primarily close both upper lid and lower lid soft tissue defects. Here's an example of a classic ophthalmic trauma where there's ocular and adnexal trauma. You can see the CT scan shows a busted eyeball, on top of which complete loss of the lower eyelid tissue, the medial canalicular system, and he had an orbital fracture itself. So these are patients where no matter what you do, it's very hard to get because these tissues tend to necrose and you may have to do multiple revision procedures. So whatever you can do the first time around, globe repairs, put the globe back together if necessary, and primary or a secondary orbital implant, and then put your eyelid back together. The best you can reform the ocular socket surface, and that's very important to ensure that you are able to get a reasonable socket, and no matter how much you do, sometimes you have residual deformities. So finally, touching upon tumor defects, look at it as fresh or tumor defects or old defects. Talked about raw, making the edges raw in older defects itself, especially most procedures. But a lot of times when you do the primary tumor resection, you can freshen the defects and do tissue mobilization. Repair like with like. Posterior lamella should be opposed with posterior lamella, anterior lamella should be opposed with anterior lamella. And only don't have any regional opposition, then you try to harvest tissues from elsewhere. I generally try to avoid lid sharing procedures in children and adults, even in binocular patients as such. So these are principles that you should be aware of. Benign defects, you do not need to have clear margins. When you have malignant defects, make sure you do have clear margins and keep the repair as simple as possible, as complete as possible in one go. Keep it as aesthetically acceptable as possible and do it as fast as you can, because if you're doing it under local anesthesia, patients can only lie down for so many, and make sure that if you do a proper job, you keep the follow-up to a minimum as such. So here are examples of patients with large lid tumors. In the past, we used to give them oral steroids or intralesional steroids. Nowadays, oral propranolol. You're able to ensure that there's absolutely no defect, no surgery at all for this child itself. Of course, you have benign tumors where you can have lower lid lamellar defects. You can replace like with a simple skin graft in modular technique, and you're able to get good results. Here's a child with a massive neurofibromatosis. As you can see, staged reconstruction both in the upper and lower eyelid and the midface, where this child was given up for blind in the left eye. We were able to get a good visual recovery. And finally, malignant tumors, make sure the diagnosis is accurate, correct. Make sure you do have clear margins, and that's very important. Basal cell carcinoma, minimum 2 to 3 millimeter margins. Sebaceous gland and squamous cell carcinoma, minimum 4 millimeter margins. That should be the take-home message itself. As you can see over here, once you do a primary excision, you can do various forms of regional flaps. Elderly patients have enough upper eyelid tissues, but when you don't have enough soft tissue, anterior lamella or posterior lamella, then the wide excision and undermining a modification of a Tenzel's flap, so to speak, which gives you the anterior lamella, and the posterior lamella can be repaired either with a periosteal flap, a tarsoconjunctival flap from the upper eyelid, or a tarsoconjunctival graft from the upper eyelid, same side or both sides can be done. Here's an example of a sebaceous gland carcinoma where a wide excision reconstruction can be done over here, and likewise an extension of a Tenzel's flap is a mustarde flap, and sometimes somewhere in between can really reconstruct eyelids as well. So in summary, I think lower eyelid reconstruction is challenging, but sometimes actually if you adopt the good principles, you're able to do it. A lot of times these lid deformities can be prevented, avoiding wide excision in benign tumors itself or not medical conditions. Keep it simple. Do not forget to get margin clearance. We do see a lot of tumors where there's a lot of regional recurrences which needs to be done. And finally, it's not just structural reconstruction, it's functional reconstruction, keeping aesthetics in mind. And like everything else in life, the first time is the very best time. Thank you very much for your kind attention. I think we have about 10 minutes for a quick question, discussion, and comments. And Farzad, you want to go ahead?
Thank you, Dr. So I will start from you as speaker. I enjoyed your talk actually regarding the safe margin for removal of the tumor. I may add that I prefer prosections or actually margin control with microscopy rather than just 2 or 2 millimeter for BCC or larger for melanoma. So you know that especially for subtypes for different grades of the cancers, there is no limit, no special shape. It's not just circular around the epicenter of the tumor that you can guess that I'm sure that I have to remove just 3 millimeter just around. But sometimes we have like pseudopods. It travels very deep inside the basal lamina. You cannot see in surgery. So
the pagetoid spread, so to speak, especially here. So the millimeter margin we talked about is just a guidance. When you go from basal cell to squamous and sebaceous gland carcinoma, margin control is very important. Good point here.
May I add more comments here?
Yeah.
Do we have time? Can I add more comments? So I enjoyed the talks about the very difficult subject in oculoplastics in cryptophthalmos and the actually colobomas. For those cases that have partial colobomas, that we have some stumps remain, actually the problem is much simpler. But for cryptophthalmos, it's a really tough job, and many of the colleagues suggest that do not touch these people. Although personally, I have good experiences with these cases, but it's really a tough job. And I would like to add, like I enjoyed the presentations by my friends here. We need to address that synechia, not just eyelid reconstruction. We need to form the fornices by buccal mucosal grafts and reconstruct that fornices. And also, I need to add that some of these cases with abortive cryptophthalmos, we have some problems with superior levator muscle. So in these cases, you may have severe lagophthalmos after operation. You should consider that in your patients as well. Thank you very much.
It's actually mentioned in literature that there is rudimentary levator aponeurosis present. So the conjunctiva of the lower lid usually is stitched to that aponeurosis. Maybe that works a little bit for elevation of the upper lid. We had planned for fornix formation at a later stage. There was a residual symblepharon superiorly, and we had planned for fornix formation with mucous membrane graft or amniotic membrane or whatever. So this may be done at the same time, or this may be done in 2 stages.
Professor Tayyab, yeah.
Thank you very much. I just had 2 questions from the first 2 speakers. The first is from Dr. Zubair, and that has already been partially addressed by you and as well as by Dr. Farzad. But still, I believe that the adherence or symblepharon is a very challenging task. I mean, to repair the upper lid by switch flap or curtle beard probably is an easier task, but to maintain a separate upper eyelid and the globe is a very difficult task. And I think we need to discuss more when the time is there. At the moment, I think the time doesn't allow that.
Just a quick adder there. So when you're doing phonics reconstruction, keep a low threshold to use symblepharon rings. That's something that maintains a phonics, because you're right.
Yeah.
You can reconstruct the phonics. The natural tendency is for it to scar. There's something that, but when you do symblepharon rings, make sure you adequately lubricate the cornea, because sometimes it's a standoff, the cornea can become dry, but it's a simple thing I thought I should let you know.
Yeah.
Go ahead. Yeah.
And second is to Dr. Professor Abrad. He talked about ptosis doing with Proly. Well, people do this procedure, but will it not be better to use silicone string or something like that instead of Proline, because Proline has greater away, and it's more of, anyway, this is a temporary procedure, but still there are choices available.
Professor Hussain, yeah.
Thank you, Professor Tayyab. Yes, you are right. Better choices are available, and the best one is fasciolata, of course. But in children, we can use it, and I have the experience to use it in men children. I keep it a bit higher. You are right that it does slip, and 1 millimeter slippage after 1 or 2 months is there. There are under correction or slippage of other materials as well, of course. But there are some advantages as well. Previously, I used to use ethibond, but there used to be a lot of cases with abscesses, stitch abscesses. So with that, with the use of this Proline, stitch abscesses are now minimal. So there are some advantages, disadvantages of different materials. So you are right. There are better material available. We can use.
Yeah, Professor Tayyab, since you mentioned it about materials as such, congenital ptosis with poor later function, believe it or not, we have a controversy section coming up in APA of Kuala Lumpur. Those of you who are coming in, please come and join us for this even more robust discussion. What is the material of choice in a patient who's more than 4 years of age? Generally, over 2, we tend to do fasciolatas when it's available, but somebody mentioned about 6. Did you mention about 6 as such? So over 6 years of age, for example, congenital ptosis poor later function, your material of choice, silicone rod or autologous fasciolata. And why? And why?
My choice is now shifted to silicone actually, because it gives more flexibility and more movement to the eyelid, and it gives a fairly good contour. I don't tend to give just stab incisions for the lid margin. I open the eyelid on the lid
Secure
crease
it.
and suture the silicone sling, the tube to the tarsal plate. It gives a very good contour as well as a good function to the lid.
Samira, would you? So fascia versus silicone?
I have given up on slings. For the last 15 years, I just do supramaximal recession.
Very good.
That's it.
Good. I was going to touch on the controversy. That's very good. Yes. Anyway, so good. So following up on Dr. Samira's beautiful talk on myasthenia gravis, thank you for sharing with us that even children get myasthenia gravis, and you're absolutely right. It happens all the time, and I think oftentimes, if you've never seen one, it's probably because you missed it. A quick question for you: adult myasthenia gravis, maximum medical treatment. What is your threshold to do surgery for that patients, adult patients with severe myasthenia gravis ptosis, who are
Bilateral.
refractory to medical treatment?
Bilateral.
No,
Or
myasthenia.
unilateral.
It doesn't matter, unilateral or bilateral. What is your threshold to do surgery for an adult patient with burnt out myasthenia
I
gravis?
don't.
You don't.
No, I've done for CPU. I've done
Right.
a lot for CPU because there's no treatment and they are handicapped. So I tell them this is going to come down, the muscle is going to come down. They come to me every 2 years and I do the resection and then they go back. There are 3 patients who are coming to me regularly every 2 years.
And
CPU, yes. Myasthenia, I nenever had to do it, actually.
and in those patients, material of choice?
I do resection, levator resection.
So even in CPOs, you do
Yeah,
levator sections.
yeah.
Wonderful, yeah. Farzad?
Thank you, Dr. Samira. I enjoyed your talk, actually. We did very good instructive points there. So addressing first the question of Ganga about when do you do operation for myasthenia gravis, I may share my experiences. I'm seeing cases that coming to me or referred to me because I have ptosis despite I'm taking prednisone. I've done thymectomy, I've received prednisone, and still I have kind of asymmetric ptosis over there. Make sure that your patient is under full control of medication. I've seen many of these cases when we increased the dosage of the prednisone, that ptosis was gone. As Dr. Samira beautifully mentioned, this is like a neuromuscular junction disease, not like myopathic disease. But I've seen cases with long-standing myasthenia gravis, especially in the adulthood or in senescent ages, that show ptosis despite maximal treatment. It's very rare, actually, Ganga. But in these special cases, I counsel the patient seriously, and after that, I will go for levator resection very conservatively. So this is for addressing your actual question. First of all, to make sure about good control of the myasthenia gravis. Second part for Dr. Samira, you beautifully mentioned that myasthenia gravis is a great imitator for different kinds of the strabismus in any age group. And how do you work up with them? Do you start with like fatigue test, ice test, and how do you weight that? And when do you ask for actually antibody test? When do you go for prednisone or other things?
In kids, we call them to the all these spiritus treatment. We don't get tensilon, so we get neostrictine. Very cheap. It's there in every operating theater. Atropine. All you need is atropine and neostrictine injection. So I have my anesthetist with me, and he does the prostigmine test. And for adults, we do it in the clinic. It's just in 10 minutes you get the diagnosis. As soon patient comes and I call him, we do the test in the clinic and we get the diagnosis. In children, we call them to the theater. In children, 3-year, 4-year, even 6 months old, even I've done it on 3 months old baby. And we call them to the theater and there he does it. And we get the diagnosis. In children, usually the prostigmine test is negative because they have other antibodies present to the acetylcholine receptor enzyme, anti-MuSK antibodies. So these children, they don't respond to pyridostigmine. They need allobuterol or they need, there is a new drug called 2,3-diaminopyridine, and their babies with the congenital myasthenia syndrome, they respond to these drugs beautifully. And those adults who are not responding, I'm not giving them now allobuterol, and they are responding.
Interesting. Yeah, thanks.
Yeah.
Yes, sir. Did you want to make a comment?
Yeah, no. Just in regards to the previous discussion, I've up in Canada we have a large French Canadian population, so ocular pharyngeal dystrophy is very very common, and I've inherited a huge practice, and for much of my career I used a silicone sling in both kids and adults. Now with anybody, no matter what the levator function is, I've switched entirely to levator advancement or resection, and have had just fantastic results, and whole families are now coming for this procedure. So I still do sling, especially in children, but in adults, I basically now just entirely do levator resection or advancement.
Yeah, I think those are very important points. So the evolution, the pendulum keeps swinging to and fro, and we are moving more and more away from alloplastic material. Just last question: how many of you in the audience do routinely brow lifts in your practice? Brow lifts. So I think that's one of the most underutilized procedures in orbital-facial and oculofacial surgery. Maybe since Farzad is from Asia and Yasser is not from Asia, but he's from the other part of the world, the scarring that you see between ethnicities with open direct incisions, would both of you like to comment? Right.
Well, I may come from the north, but I'm from Toronto, which is the world's most multi-ethnic and diverse city. And especially in one of the cities I practice, 60% of my population is South Asian, Indian, Pakistani, Bengali, etc. So I've got a huge South Asian population. Of course, scar always forms, and definitely, I mean, from the darker the skin, the higher risk of a scar. I myself have not had a problem of course, nothing unusual. Of course, scars are a risk and they do happen. I'm not saying they don't happen, but nothing unusual, even compared to, I've had some Caucasian patients who have had scars as well, but they're minimal. They typically almost always go away, especially if it's a small incision. Even the direct brow plasties in the right patient, the scar does eventually fade where it's not significant. So, I always warn patients about it, always, but the risk of scar doesn't prevent me from doing the surgery as long as the patients are aware and are expecting and are informed.
So let me clarify first. When we are talking about brow lifting, and before we talk about scar, we should understand which technique is preferable for this patient. Like lateral brow incision is not good for a patient with total brow ptosis or medial ptosis or asymmetric brow ptosis. First of all, we should think which technique can solve our problem. The second issue, as Ganga asked, I may address. I had the experience of working both in the States, in Europe, and in Middle East. So I've seen different types of the races. I've worked with them. To me, Middle East people are very tough to handle from the scar formation, and the people cannot tolerate even minimal amount of scar for years, and for the whole year. I've been actually lots of people are referring to me because of the minimal scars, and it's like hell for the surgeon. So for different races, we have different amounts, different actual type of tissue reaction and scar formation, especially for the Fitzpatrick like 4 or 5. Be very careful about skin incision over that people, especially for the exposed area. You cannot camouflage the scar over like suprabrow. It's really difficult. And I can say you should counsel a patient very clearly. I mark for my male patients. I mark there and say, go and look at the mirror. Do you like it? And you believe me, 50% of them say no. I cannot tolerate that much scar, like 1 centimeter scar over there. So be very careful about the patient. Make a good selection of your cases.
Just to add,
last comment, and then we close.
No, I've operated a lot in Bahrain, Dubai, and Saudi Arabia, and he is right. So Middle Eastern patients are very unique and extremely high maintenance. So I do agree completely.
So in other words, they're all saying as surgeons, they're all racists in their clinics. So in the interest of time, I'll have my co-chair and moderator conclude the session with learning points. Any concluding remarks?
Thank you to all speakers. It was a very good session. A lot of discussion was made at the end, and we learned a lot. So with this, we conclude the session. And now I request all the speakers to come to the stage for a photograph, group photograph, please.
Thank you.